Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 140. I hope you're all staying safe from the COVID pandemic and that almost all of you have been vaccinated, hopefully with both the doses. Stay safe. We have an interesting complex coronary intervention today based on your feedback. We've been trying to do more CTOs and we have a planned CTO today. Not certain if it is going to be retrograde, but we'll let that come in our discussions. I'm delighted to introduce to you a person who's most aptly suitable for this topic today, Dr. Emmanuel Brilakis, who's the director of the complex coronary interventions at the Minneapolis Heart Institute. Brilakis, good morning. To me, Minneapolis Heart Institute till today represented Tim Henry and his work with the level 1 heart attack program in which I had started my involvement almost 22 years ago. Pleasure having you on.
It's a pleasure. Thanks again for having me.
Samin, good morning. You and Anu are already there, scrubbed with the case. Further on, just to let you know about Dr. Brilakis, he's the probably, I think, as our discussion will go, we'll be talking a lot about Progress CTO, the organization which he founded, which has possibly the biggest ever compilation of CTO cases. Just about every publication, every aspect of techniques, right from the moment of introducing the technology to the field, training thousands of interventional cardiologists, taking it globally. Dr. Brilakis, congratulations. I actually had been familiar with that various publications, but last night in preparation for your introduction, I read more about it, and it is absolutely astounding, the almost, I think, a decade of incredible work you have done in that. Samin, good morning.
Yes. Well, good morning to all our the viewers of CCC Live, episode 140, global audience, and a special thank and welcome Dr. Brilakis for his expertise. We'll need a lot of help from him, as you mentioned, with the Progress CTO, and of course, part of the discussion. This is actually retrograde, of the 140. We had done only 4 retrograde cases, and last one was more than 2 years ago. So this is the right case for that purpose, because there have been a demand of more CTOs and especially retrograde, and this we found the ideal case, and with the extreme help, myself, Dr. Keeney, my left side, and our fellows on the right side, Suvan and 2, will, with my cath lab staff, welcome everyone, and we start as usual presentation of the case and rapidly then go through actual performance by Dr. Keeney. So we can slides. These are our supporters. Okay, somehow the slide set is not working here. Why it is not working? Anybody checked it? Sorry. Okay, good. So these are our disclosures, as Samir Mehta is the moderator. Somehow still we'll try to see. No, but why this is usually it. You cannot be talking. Doctor, we welcome as a guest faculty. So somehow my remote control, they'll try to see this battery issue maybe after this next slide. Make it a next slide. So we'll do a manual. So this is a case number, as mentioned, 140, 56-year-old. Patient actually presented late last year to outside hospital with chest pain and positive stress test, and had only thing is uncontrolled hypertension. At that time, basically had a significant inferior wall ischemia, cath done, had 2 vessel disease, very complex RCA, which we are going to show now today, and had already diagonal lesions which were stented. And now patient continues to have still symptoms.
They failed CTO outside.
And they tried also? Yeah, they did try. gingerly they showed one shot only of this RCA, the revascularization, which was not possible. So just put a stent in the LAD and the diagonal, 2 in the LAD, 1 in the diagonal. But patient continues to symptomatic because obviously because of the inferior wall ischemia. And here we are now for revascularization of the RCA today. So this is why we said just go with the, I'll discuss with the CTO hybrid algorithm. In this particular case, EF is about 50%.
Yeah, the EDP about 10, and you see the inferior wall is hypokinetic, and this is where we are. So engaging the RCA was not easy. This is a JR catheter. We had to use a no torque catheter. Then we were able to get the RCA ostium. You see there, occluded proximally, and large size vessel.
And long segment, more than 20 millimeter. Because that will come into discussion.
So luckily the stent is in the mid LAD. You have the first septal, which is fanning with a lot of collaterals. Probably now you see there is, angiographically a connection to a branch of the PDA there.
So let's ask Emmanuel, what do you think in terms of the retrograde and knowing you have the better guide picture, right?
We didn't take guide picture, no. We are just worried. Now we have a Lima guide.
Yeah.
That's able to get the Lima guide engaged.
Picture then. Retrograde. Yeah. So question is, with your expertise, in this case, with your hybrid algorithm, will qualify to go to retrograde?
Yeah, so I think if we go by the 4 characteristics, the key thing here is that the proximal cap is ambiguous. You have this little marginal coming off. So it's hard to tell exactly where the right occlusion is. So that's a problem for going undergrade because you may perforate and have problems. Then, as you said, it's a long lesion length. The distal vessel is of good quality, and you do have good collaterals. So I do agree that this is a case that in which you could try to use undergrade, but I think it's very reasonable based on the hybrid algorithm in general to go retrograde as a primary approach.
Good. Let's just
Emmanuel, what would be your access preference here?
So I see the hub bifemoral, which I think is great. Quite often we do now femoral radial. We use the femoral for undergrade, usually 7 or 8 friends, radial 6 or 7 for the retrograde. But I think for complex cases, it's always nice to have the extra support. So personally, I'm a big fan of, say, femoral and using ultrasound guidance as well as fluoroscopy to get femoral access. So I think bifemoral access looks great.
Excellent.
Okay. Anu, tell us what is your strategy now?
I think we'll go with the same with that first septal. We are going to start surfing the septal with the Fielder FC and Corsair. We have 150 Corsair, so that's why once we are going retrograde, Corsair comes in 2 lengths, 130, which you can use for other anti-grade approach if you're doing it for over the wire, any other procedures. But when you are doing retrograde, you need a longer one. So we have 150 Corsair, and of the various retrograde wires, we carry only few of them. So we're going to start with Fielder FC. Fielder FC again is a polymer jacketed hydrophilic wire, which has a tip load of 0.8. It's not tapered. It's a good one. If you don't have Fielder FC, you can just try with a regular Fielder or Whisper, whatever you have. And I think we'll just start with Fielder FC now.
And just to complete our presentation, if we can go back to the slide, because all our presentations include the OC discussion. So somehow...
Hold on. Yeah.
Okay, so this head is still not working.
Regular Fielder.
They have to... Next... Okay, good. So plan what he's probably doing it now. So this is our retrograde through septal collaterals. And next, always in our discussion, always in the first one, that all presentations in terms of appropriate use criteria. And if we can go to the next slide, and so that we start the actual work and the discussion. So this case basically is a non-LAD, no proximal LAD or proximal circumflex, the intermediate to high risk findings on non-invasive testing, and is on double anti-ischemic therapy. So it will be appropriate criteria. So with that note, Anu, you start now. So we are going with the Corsair and
Turnpike, and what's the other one?
Yep.
Bring it.
And the Fielder Which one you are starting with, FC
No,
first?
actually, no, I'm going to start with the regular fielder to get into the septal, and I think when I'm reaching way further down, then I'll use the fielder FC.
Okay.
I have to make a turn into the first septal.
Yes.
Dr. Brilakis, would that be your preferred approach also to begin?
Yeah, no, I think it's perfectly reasonable. Sometimes you just use a workhorse wire to get
No,
into
but
a
what is
septal, but I
happening?
think
You
a
want to get
polymer is
another
perfectly
one?
fine.
Get us some other shit. This is
Now, the
bad.
one thing here, I see the septals are very small. So sometimes for those small septals, a smaller microcatheter like a Corsair XS or the Turnpike LP may be a little easier to get through the collateral. But again, I think it's very reasonable to start with the Corsair, and then if there is difficulty crossing with the microcatheter, you can always switch to a smaller one.
Excellent.
We do have a Turnpike LP ready if you need it. Turnpike LP also comes 150. Both, we carry 150, yeah.
The other thing for the audience, I guess it's good to have, if sometimes short guides when you go retrograde. Now with the R350, the long wires, it's, I know we can still externalize most of the time, but sometimes when you have difficulty the length, having the 150 microcatheters is, and short guides,
It's not there, some die.
Excellent.
Can we go this?
And the FCL.
I think we're okay.
Yeah, actually, we used to worry about those short guides now. With this longer micro catheter, I think it's maybe a less of a, in the past, you used to cut it and so forth.
Yes, that's right. We used to cut them a lot, but right now I think usually we don't in general, except we don't have the right shape. But yes, absolutely, cutting is an option as well.
Emmanuel, you have CTO scheduled at the Minneapolis Heart Institute every day?
Yeah, actually, we do CTOs on most days of the week, so we don't have specific CTO days anymore. And you know, in a way, it works well. In the past, we used to have like CTO days, 3 or 4 cases a day.
Some die.
And
No, it's not that.
If one case goes long, then the whole schedule is off. So
How many?
regular.
Go to caudal view first.
How many operators dedicated?
2 operators. It's Dr. Burke, Nick Burke, and myself who do CTO.
And with most of the cases being referred and the majority having had attempts at other institutions?
Go now, other view.
Yeah, about 60% of the cases, 60-70% of the cases we do are referred from outside institutions. Many of them are outside failures. And, you know, that's another reason not to have.
I think we may need a run through here.
Okay. Excellent.
Get a run through.
Yeah. So
Truly
truly the flimsy wire has you got trouble getting into the LED, but you can go a little further with the micro catheter. I mean, this is the Corsair. They put 2 stents in the mid to distal LED far down.
Hold on. We were able to get through.
Yeah. So now, Manuel, what happened if there is a stent already in that across the septal? What has been?
So you can still use the septal even if you have stented. Sometimes you may have to balloon it with a 1.5 or a 2 balloon to make a little space. The one thing you have to be careful, I guess, sometimes the wire might cross under, but it looks like here you're going fine. So if it goes fine, you have no problem. If not, you can use a small balloon to get through. But it looks like you got through.
Yeah, in this case, actually here, the second septal does have some collateral second and third. Those are with the stent. Proximal, at least luckily, there is no stent in that proximal septal yet, across the proximal septal. So that's a good, I mean, first septal. Okay, so now the wire going a little bit.
Okay, let me see. Now forget the fielder FC. Now let's take a good picture.
Okay, Shane.
Hold on.
Yeah. Now, what about giving the intra microcatheter injection? I know a lot of people do it. We try to avoid because we have seen a lot of septal hematoma, diastasis. In what condition will you give?
I think it's very reasonable to do both. I mean, here you could do an injection. The key to avoid these hematomas is actually to aspirate first, make sure you have good backflow. If you do that, then it's unlikely to have a problem. But I think here, given that there's multiple connections, it's very reasonable to just surf with the polymer jacket wires you're doing and see if it goes. And maybe after 1 or 2 minutes, if it doesn't work, then switch for injection.
Yeah. Okay. So here, so question is the bifurcation is little proximal. See that?
No, but that's not connected.
No
Get
proximal?
B filter FC. Let me try to
Okay.
make a.
So another
This was the
option
regular
here,
fielder.
I don't know if you have a SUO3, that might be another option. SUO3 works well for tortuous collaterals.
Yeah,
And sometimes the
SUO3 we
Black
don't
also
have
is
it.
very good.
Yeah, we don't carry
Yeah,
that.
we
Okay.
carry it. We have to start working on that wire, particularly for the retrograde point of view. So short band, same.
Yeah, typically 1 millimeter, like one millimeter, 30, 45 degree bend, so very small bend. And then again, it's a big movement with a lot of spinning.
Give me a new
Typically,
one.
we don't use torque for this. We're
Yeah,
going through the septal for surfing.
No, fielder FC. Yeah,
Wow, this is no good.
already see that.
Yeah, double curve. Yeah, so
Yeah.
we got a new one if we have.
But look at this septal. It is angulated septal, not like a straight. If we don't get the fielder FC through that, then we'll try the first
So I don't know if you
septal.
have a Xion wire, maybe Xion wire or some other
Xion we
non-polymer
do
wire,
have.
it might as well.
We have the Xion, right?
No.
Okay, so it's possible to use like a Xion blue or some workhorse wire as well to try to get through those. And there's many
Give me the
septals
thing.
here. So let's say this doesn't work. You do have, looks like the third one, if I can see it well, has a very good, more straight connection. So if you cannot make it through the first, the third septal might be actually a good option as well.
Right. So only question is what third, as we discussed,
Is
that we may
through
have
the
to open
stent
the
strut.
ostium of the stent strut. But yeah, it
Right.
looks like a better connection with the third one. Yes.
Straight.
Good.
We'll try this for a little while. If it doesn't go through, we go directly to the.
Yeah,
Take it
absolutely.
out.
And the other thing is for the ACT, when you go retrograde, it's good to have the ACT 350 or more and have the nursing staff check it from time to time, make sure that the patient doesn't get any thrombus. But otherwise, I think, again, it's important to just keep on trying
Angiomax.
different things.
Yeah. Okay. So good. So now we have the fielder.
FC.
FC. Okay.
Which is what you wanted to use in the beginning.
Yes.
It's not going in the PDA.
Is that
Yeah, and
septal going
it's not
this way and
uncommon
then
for the
coming
wire sometimes to buckle. So again, just more spinning and just back and forth gently. Sometimes it just slides through and just has to find the right channel. But again,
Other question is, should we pull back the Corsair because there is the one parallel that branching septal. Maybe we need to go to inside one. So right now we may be a little outside.
That has no connection.
That one, yeah. Try that one, yeah. Advance the Corsair a little more.
Yeah, that's okay. No.
Let's see.
Usually should fly.
Yeah, no, but
Man.
right now, yep. I think we should get a Corsair a little more and see this now. You want to take a picture?
It does not
yeah, I
look
think,
right.
this does not
Does not look
doesn't
right. Yeah.
promising.
Yeah.
Okay.
Going out.
Yeah.
Okay. Let me try here again. Not that one. Go back here. Otherwise, we go to the third septal.
It seemingly keeps tracking exactly to the same area.
And the
Now it's a
reality is
different
that, 20% of the time, the septal cannot be crossed. So especially these small septals, even if you do, everything you can, there is 1 in 5 chance won't be able to cross it with a wired microcatheter. So it's something that it's inherent in doing retrograde.
Huh. Okay, let's see here again.
Yeah, this is your original channel now. Yeah.
It's just around there that it.
Here.
Here you may need a little more support with the Corsair.
No.
No.
Emmanuel, between the Turnpike and the Corsair, you have a distinct preference?
I think they both work very well. I think the Turnpike has a spiral version, which is for many people their go-to undergrade microcatheter. Has a little extra coil, can give you a little extra support. For retrograde, both the Turnpike LP and the Corsair XS are torqueable, small diameter microcatheters, and they both work pretty well. So it's a matter of comfort, which one you stock in your lab, which ones you want to use. They both work very well.
No.
No.
Want to go to the third septal?
I mean, it's looking like more and more that third septal looking more promising. Yeah, what happened?
Somehow.
What happened there?
No, I think it's going out, SS. See, the PDA is inside. We are going somewhere else.
Yeah, I think the third septal might be a better option.
Okay. You want to go? Third septal. Only question you see is way further down.
Right. You'll be struggling with the support there much more.
I'm trying to see if I can serve some other septal here. Okay. No.
What about this? Yeah, that looked a little promising. If you want to move a little more of your Corsair. I think we should try a little more on this before go to the third septal, because...
No, we have to get to the septal faster. Then we have a long way to go still.
Yeah, you could.
You want to give us a...
change something, the bend of the wire, do some change. So because this wire seems
give
like
it a... Yeah, it's not going anywhere.
FC.
Get us a run through. Stiff tip.
Or Xience.
Or
Xience.
we carry Xience blue? No.
We are Xience blue, right? Yep. Yeah. Let's try the Xience.
I don't know.
Emmanuel, I want to take this opportunity and engage with you a little bit more, more with the Progress CTO. Were you initially, it's been almost what, 8 years, 9 years when you founded the organization and created such a behemoth international group?
Go.
Yeah, it's been almost about 10 years. I think 2011 was the year we launched.
Okay.
Actually,
Don't say anything. Don't waste your time here.
How much, what
Good.
inspired you initially? Was it the work in the Japanese were doing?
Yeah, it's an interesting course of events. As you know, Japanese started the retrograde, started some of the complex CTOs, and then the US took over, Bill Lombardi, Craig Thompson, Mike Wyman. And back in 2010, there were a lot of early meetings, the launch of the crossbow Stingray system. So a lot of things happening in the US at the time. And the initial goal was to consolidate the US experience and say, how can we best learn and do this in the best possible way? And then that's just slowly grew. The initial one was with Dimitri Karbaliotis, Bill Lombardi, and ourselves, and then slowly grew up after that with more and more centers. And we've learned a lot over the years.
So are there any centers in Japan?
No, so Japan has their own, as you know, the expert.
Right,
Japan
that's what I was thinking. So what happens, Emmanuel? Are you still accepting more sites? I've already had 2 questions. One is, I cannot make out the region from India. Are you accepting more sites, and what does one do to qualify?
Yeah, no, absolutely. Would love to get new sites. Again, this is for people who have some experience in doing CTOs. And then the way
have you defined the annual number or lifelong?
We want them. Yeah, we want them to have to have done at least 50 CTOs and to have a success of at least 80%. These are the numbers we typically use. And again, depends on the experience. Some early people who've started, but they've been trained very carefully, can be included as well. And then to participate, if you go to progresscto.org, there is a join group button. You press it, you enter some basic information, they will contact you and collect all that information.
Excellent. To you, what has been the most satisfying part of this? Has it been an ability to continue improving technology, to publish, train people, all of the above?
The reason for this, to start with, has been the learning. There's been a lot of learning coming of it. The perils of the retrograde approach is great, but does have some high risk compared to the undergrade. And trying to understand this better has been, one of the areas of the registry. Also working with many people around the world and learning from each other. And also many trainees have been able to analyze the data and also themselves learn and advance their career through this. So it's been all of the above. It's been a tremendous learning experience and growing experience for everyone involved.
So everything expected with the third septal here. I can see the struggle with the support, but indeed we are there now, and let's see if the wire behaves a
little better.
Yeah.
No, it's still not going into the septal.
Right.
Not going to the septal of the PDA. Septal of the LED is good, but not septal of the PDA yet. Let's see.
I don't know if septal 2 may be okay. This is not
septal
behaving
2 also.
okay.
You're here. You want to see it?
Yeah.
Ready?
And if you can get a microcatheter in the septal, that might help. It looks like you may have some difficulty. They may have to balloon that stand to get the microcatheter a little closer,
but definitely more promising than the first septal, I can see.
Yeah.
And sometimes it's better.
You see the bend, the way the septal is moving and the bend of the septal, it's not a good sign.
Yeah. Those actually, the bend have been associated, the collaterals, bend, septal collateral have been associated with the unsuccessful.
Perforation, yeah.
And unsuccessful, yeah.
You mentioned.
Some die?
Yeah.
All right. You made a lot of progress there.
This, I think this, you may want to move the microcatheter back a little bit. It might be a little too far down, and then that limits your options for crossing. And this, given the difficulty, it's not unreasonable actually to try a small injection with a 3cc syringe and just see the connection. There was a pretty good connection from the previous shot you took.
Okay, we need a better wire, I think.
Yeah.
Get us maybe we go with a whisper. This is
Other
not going
question
there.
is that do you want to do a micro injection? Not
This
yet.
one? You can, I guess. You want to inject? No.
Which is the other wire?
I still think, go take this out.
Okay.
Anti-grade may be a better approach. Be done.
What do you want?
No, get me a run through so I can make a better curve. You want to inject? Not see anything. Some die.
Yep. Yeah, but you have to aspirate first.
No. So
No,
we
aspirate.
no need. Okay, you don't see much. See?
Nope.
So I don't like it.
I mean, this was definitely angulated of that septal collateral also. So here, let's see any second septals. No. Other question is now, since we are having a little difficulty here, should we just poke the antigrade, huh?
I don't know, maybe go to this view. You give that
the question is, are you in the same septal that was, because in this view, it looks like the third septal has a pretty good connection. So I wonder if you're in different branch.
Yeah, we are going back to the same view to see we are in the right septal. Go back.
Yep. We are going to RAO 28 cranial.
Go.
Okay, we are in the same view now.
Same view?
Yep.
Looks to be the right one.
No, your septal is the same, but it kind of burst
The
open.
direction
So it's
is it?
smaller. No, it just, I think what happened, it just opened up. Or you can maybe a little micro rupture and nothing there now.
Yeah, that's how it looked with the injection which you
Yeah.
took. So Emmanuel, here just thinking out all sorts of options, any role of imaging here?
Yeah, so here it looks like if retrograde doesn't work, which it may not, then the next question is how do you clarify the ambiguity of the proximal cap? One option is to put a wire into the marginal and then take an IVUS and just see where the proximal cap is. That's one option. Sometimes, I mean, here is not an option, but if you have before a CT angiogram before the procedure, you can actually use that to try to understand better the anatomy in the proximal cap. And then another option here might be to just go into the proximal right coronary and do dissection, the so-called move the cap techniques, dissect, and then use a knuckle to go around and re-enter further down. The vessel does look fairly good quality distally, so that's another possibility here.
No, Samdai?
Anu feels different this time around.
Yeah. So then,
Yeah, a picture there might not be a bad option to look better where the wire is.
Right. It's moving more freely, I think.
okay.
Sine?
Yeah.
Okay. No.
Way further down, right?
Yeah, way further down.
Yeah, and the challenge here also is that you have a wraparound LAD. So the PDA is actually a fairly small vessel. So that's part of the difficulty you're having.
Yeah. Yeah, it tethers out in the mid portion, as you can see there.
What's the ACT you have?
Good.
Okay, saying go. High because of the thing.
Give heparin. Yeah. 3000 heparin, yeah. So now you want to
Go antigrade, right?
integrate the guide. You need another catheter. Which one do you need?
No, we'll use,
Turnpike?
Only question is, do I try Gaia with the smaller curve to get into that?
No, what about manual using the Gaia in this situation, Gaia 2 or so? Won't work in this, right?
On the undergrade, you mean?
Yeah.
Not antigrade here, retrograde.
No, antigrade, definitely we are going to go with that. Question is, before we give up, do we need any stiffer wire? I think all...
No, I would not. I would not.
No.
I mean, stiffer wires will probably perforate that branch,
Yeah,
so you
right.
want soft wires.
Agreed. Okay.
Get the whisper before I finish.
Right. Anu, I was going to suggest exactly that. I said,
Okay.
softest handles the tortuosity well. So Emmanuel, you're back in Minnesota, where your journey started from the Mayo Clinic with the years down south in Texas. Absolutely remarkable course going back. How much is the mean fluoro time now recorded with the Progress CTO and the volume of the contrast and the radiation levels for the retrograde?
Sure, absolutely. Well, it's more than with the undergrade, but
Right.
actually we just had a kind of analysis over time from Progress CTO about the radiation, and there has been a significant decrease
Right.
with over time. And actually, Gerald Werner just recently had a paper, I think last couple of weeks in CCI, showing exactly the same with the Euro CTO group. So, although retrograde still has more radiation, but the reality of it is we're using a little less retrograde, and overall the machines are getting better and people are getting more careful in terms of using radiation. So actually we've seen significant reduction in in the dose of in the radiation dose.
So that actually brings us to another very interesting observation, which I had noticed that you actually in one of the abstracts, I noticed there was a significant difference even within the different equipments. With one of the Philips system had a statistically lower rate of radiation. That came as a surprise.
Yeah, so the newer machines have much better algorithms for reducing radiation. So the Clarity system has had significantly lower radiation than the older systems. The same for the Siemens, the QGen, that also has low radiation than the previous system. So the X-ray alone can play a big role, but of course the operator and the use of 7.5 frames and using low fluoroscopy, that also can play a big role. But the current median radiation is like 2.3 gray. So it's not perfect, but it's come down quite a bit compared with the previous time.
Have your own radiation dosimetry levels been high enough that you were forced out of the cath lab for some period of time?
They have not, but I must admit that I'm a paranoid person about radiation.
Right,
and I'm
absolutely.
Zero gravity. So the zero gravity actually really gives you better protection. It's a no lead holding. It's a system that's hanging from the ceiling,
right.
And you get pretty good radiation protection and less chance for back injury.
Excellent. How many institutions in the country have it?
I don't know the exact number. I know Montreal is using it quite a bit. Missouri is using it quite a bit. So I think not many places, but many places who have it are using it. And now there's another system called the Rampart, which is a system of shields that the operators in the lab don't have to wear lead because it cuts back the scatter radiation.
Right.
So a lot of activity, I think, we'll be seeing on this in the months and years to come.
Which is really where I found the work of Progress CTO truly remarkable. There are areas of radiation where it has advanced the radiation exposure. I mean, even works in gender, and truly congratulations for spearheading such an important body of work. More thoughts, Emmanuel, here? What should be attempted in this case? How would you be handling the situation?
Yeah, so obviously it's a challenging one, given the difficulties with crossing. The options here are to go back to I think they're trying to go back to the first septal and try again with a different wire, maybe a different course. That's one option. The other option here might be to just go undergrade and do a brief undergrade attempt, maybe put a wire into that marginal branch and do intravascular ultrasound and see where the proximal cup is. So there are different options here.
Get ready.
Got it.
Yeah. Okay. So what happened? You want to try once again the first septal one?
Yeah, I'm trying to see with the whisper. I never tried. We'll try. Otherwise, we are ready for the. Get me another one because the tip is small. Get the larger, the fielder again. Let me get
Emmanuel, the Minneapolis Heart Institute is still a leader in that part of the region in STEMI interventions.
You want to go anti-grid? Yeah?
I guess do a lot of interventions for ST elevation. As you said, Tim Henry really is, spearheaded this and he's built a great network. Of course, there are many centers who do now primary PCI, but we still have a lot of transfers, especially for the complicated cases, cardiogenic shock, failed reperfusion, cardiac arrest. So we see a lot of those patients who have complex features and little characteristics.
How did your STEMI cohort, did you end up doing things totally differently with the pandemic?
We've seen obviously that's a good progress, by the way, but on the Guire. But we've seen initially, obviously, significant decrease during the early months, March, April of last year. We did see an increase in the cases with late infarction. So people who come in, they had chest pain for several days. They didn't want to come in because of the concerns for seeking medical care. And then, of course, they come in and then they have a complete infarcted territories. We've seen ventricular ruptures, free wall ruptures. some really poor outcomes we haven't customarily seen. Similar kind of what's been observed in Italy with higher complexity and a more delayed presentation of the patients who have ST elevation MI. I presume the same in New York.
Right. Yeah. About the same feeling, the very early on, it appeared that we may be using a little more lytics, but absolutely back to the same methodology. But it's truly humbling the extent of their thrombosis, and had several cases present simultaneously with the
which is fine.
stroke and an MI.
Yeah, not going.
Yeah,
Okay.
yeah, the thrombotic
Right.
environment is an issue.
The-
You might consider to
catheter
pull the
back.
microcatheter back. Again, the microcatheter might be committing you a little bit too far down into that septal.
Now,
But I think the great option might be better at this
Let's go
point.
to
At this
the
point, it looks like those septals are really not easy to cross as they appear to.
okay. Yeah. Let's take a guide picture from other side now. We don't need the contralateral, but just to see where we are proximally.
Ooh.
Yeah, there's
Okay.
almost like no even original branch. Yeah,
Okay.
Anyway,
Let's see the.
we have the turnpike.
So, Samin, there are at least 3 viewers who are recommending time to move to antigrade.
All right, so we heard them, and that's what
not-
Emmanuel also not a wrong choice now. The question is, which should be the first wire? Knowing it's a very proximal, you want to go with the Gaia 2?
Gaia next.
Gaia next,
Yeah,
2 or 3, right? Because it's just a very
3. Give us 3.
okay. Now, as you can see here, now maybe you do want to take out and see if there is a marginal branch, which Emmanuel was saying that
It's
we stabilize there.
Oh, it's
So
not
now
there. Don't.
question
It's
is
very difficult
that-
to engage.
Okay. All right.
Yeah, don't touch
Let's
it.
go. Okay. Go. Gaia 3.
Why you want Gaia? You want to try fielder first?
No,
Fielder
this one will
first?
not a fielder case. Yeah.
Maybe find a lumen there.
No. Gaia. Okay. Let's take a. We took the picture. So it's here. The question is there anything proximally? So there is a one small marginal branch. I'm sorry, the sinoatrial branch. Maybe we can stabilize and guide can come out a little bit. You have the fielder wire.
Yeah, I was,
And
Samin, that
1.5
was my
balloon. Yeah.
other question. If you're happy with this, the guide, then
Go.
Pull the wire back.
Yeah. Yeah, it is there. Question is how far out. It could be a separate origin of
Oh.
the conus.
No, I
kind
did
of scientific.
try non-selective. Could not see anything.
Yeah, they try with
We'll
the
see.
diagnostic catheter earlier.
You gave a more heparin, right?
Yeah. Good. Okay.
There may be some hint that the vessel is going straight down. I think even in the delay view, there may be a little straight shot. So I think your approach may not be bad. Looks like that might be the course of the vessel, and that's very good progress, actually.
I mean, just watching.
Okay,
where
now you
this-
can give
Gaia
some
X?
dye in the RCA because it came out, guide. This is a Gaia X3. Okay, good. Some dye there. See, that's where it is.
It looks promising. Maybe worthwhile taking a contralateral picture and then maybe RAO view to make sure it's moving in the right direction.
Yeah.
And then you may well consider to get a guide extension like a trap liner to get in for support. Looks like you have support issues giving the very proximal.
Yeah, my initial thought there was that that's what we are going to confront next, and whether
And we can change it to a 7 French, right?
or AL1 or something, but
Yeah. Well, AL1 maybe the question is 7 French, so that we can put a
0.75, yeah.
yeah, that we can stabilize the guide into the
He's saying
sinoatrial branch. Yeah.
some retrograde
Yeah.
action.
No, retrograde, that little early, no? We can do the injection retrograde. We didn't come that far earlier.
Yeah, this is definitely promising.
See, one thing was, we should have gone with the Godzilla to begin with. Now, this small curve may not let us go into the way the RCA
Well, it's moving,
goes.
making progress.
Oh, you want to take a retrograde
And
picture?
now take a retrograde picture, yeah.
Yeah, you may be going in a marginal. Sometimes the marginals are there. And
Probably needs
So
to
for
come
this one,
back a little bit.
you will have to probably make a curve to get inside and maybe use a miracle now. If I can get the Corsair down. I mean the turnpike.
Definitely have made little progress. Now, Emmanuel, on the integrate, what is your preferred wire in terms of this Gaia Next? And so seems to be a little better than original Gaia with their new
Yeah.
extend coils and so, yeah.
yeah, I know many people still use a polymer jacket first if you have some source. And sometimes if you have a hard time penetrating, you use the Gaia Next or the Gaia Second or Third, and then switch to something softer just to avoid getting into branches. So here, I think it's a great progress that you've made. You might consider now switching to something softer, even a polymer, to take the bend and go down to the distal RCA. Maybe the
Do you ever
RAO
use
might help you as well.
Would you ever use a miracle? I know it's an old wire where you can probably make a curve to get into the RCA to make the turn now.
Yeah, we don't typically use it that. It's mainly for support delivery equipment. We don't use it that much. I mean, it could probably work. But yeah, typically we don't use it as much these days.
Here you want with the pilot or?
Yeah, pilot or pilot 200 would be a great choice, or a Gladius or some sort of polymer wire might not be a bad option.
Okay, give pilot 200.
Yeah, good. That's want to, right? We go with that, make a curve.
Definitely we should have had the Godzilla. The thing is the proximal RCA looks, the diameter is very small here and almost only you can see about 10 millimeters of the vessel. So that may be a issue also to get guide extension into the vessel.
And the center cross that device takes with the 7 French, I know that has changed few of the, some other company has taken that device up. We used to use it sometimes, but were not.
But you need a large vessel to hold it.
Yeah.
Between 3 to 4, we barely have the vessel size, and you need proximal vessel.
Yeah.
Sometimes
That would not have been a ideal case in this because there is no proximal vessel.
Have miracle ready also. 6. No, hold on. What happened here? Who did this? Change it.
You did what?
Let's not watch the movie.
Good. Okay, so we are back now. This is
200 progress.
yeah. No, pilot.
Oh, pilot, yeah.
Pilot.
Okay. We are going into the branch.
And maybe again, the RAO view might help you here to go straight down versus going to the branch.
Right,
Sometimes
go to
it's hard to see on the LAO.
You get a headache.
Dr. Brilakis, there is a question for you directed straight at you. Dr. Brilakis, is there a radiation threshold on when you decide to stop a case? And this is coming from Steve.
Some dye
Yeah, that's a great question. And that there's some relative, but many people, if they have not made any progress, significant progress with 5 gray, they will stop. As you know, 5 gray is the threshold you start having the increased risk for radiation skin injury. Many people, if they don't do that, then if at 7 or 8 gray, they would probably stop there. So, but most people use the 5 gray as a threshold for stopping. With the new machines, you can actually do a lot of work.
Miracle 6.
Yeah, that is part of your hybrid now, the 2.0 algorithm, right? Once you've gone beyond the 5 gray and given the dye, contrast volume and duration of procedure 3 hours and so.
That's right. So there's actually right now a global effort for creating an updated CTO crossing algorithm that there's more generalized acceptance. And one of the criteria for potentially stopping is the 5 grade. The other one is the GFR, having a contrast more than 2 to 3 or 4 times the GFR or a complication. These are big things to help you stop the procedure. But again, we've seen that radiation used to be a big factor. With the new machines being careful on the protocols, it's less of an issue now. And actually, contrast is becoming more commonly the limiting factor for stopping the CTO crossing attempts.
So now this is the what, Miracle?
No, this is Miracle 6, yeah.
Okay, Miracle 6. Or otherwise, we have the Progress 200, and the earlier tried the Pilot, didn't make much. I think the question is, the slippery other simple wires like Fielder or Whisper may not make it yet because you still have to penetrate the cap.
Get me the confianza.
Yes, I was.
12.
Sorry?
No, I was going to mention about the confianza.
You
No.
retrograde a little bit.
All right, there we go.
Take a
That's
picture.
a great move.
Good.
Chennai.
Good. Ready?
Yep.
So, Anu, which was this wire which went through? Miracle?
The great miracle.
Yeah, okay.
Miracle
Wow.
6.
That was awesome.
Excellent.
Remember, we had to make, we needed that little curve
Yes,
which
that's
Pilot would not do it. This is a good old miracle, yeah. So now, let me see if I can get my anti-grid
The
further
guidance.
down.
And
Then
we
you
can
hold
take
it.
a 2 or 20.
It's
We
not
can take a
holding
2 or
it.
20 balloon. Yeah.
So I think you'll see how I'm advancing
Yeah, keep the, sir, rotating the,
on my right hand and left hand. I'm just advancing a little bit. Corkscrew.
even if not, you can put a dark and use a small balloon 1O.
And with the,
And this is the kind of case where nothing can cross, then we go with the laser. So we have used laser, some of these uncrossable lesion when wire has gone.
this may make a progress.
Definitely
You're
see
making good progress there.
good
So
progress
I would
by
still-
spinning. Yeah.
I will still use the guide extension after you're able to change the
Yes,
wire. I will
yes,
still use the guide
we are going to do
extension
that.
here.
Not with guidance.
Huh?
Once it goes, you'll get the guideliner. I mean our the axial length run through. I think you have come all the way there. You want to be inject retrograde?
A little bit more, I guess.
Okay. So seam, holding the wire with the right fingers or the palm and then spinning.
Samir, are you able to see my fingers?
Yes.
Hands?
We see it
Let's take the
very
retrograde
nicely.
injection. I think we have gone there now.
The ceiling camera is showing its value.
Because
And
this is the key.
Yeah, we went there now.
Gentle forward, yeah. Okay.
Take
you
a
want to do-
retrograde injection, we are there. I'm holding the guide right now.
no, excellent demonstration, nice
Yeah, I will
progression.
get a little bit more if you can, I mean, just to make sure the distal
Okay.
cap was right about there, just to avoid any surprises once you change.
It will go now, don't worry. You'll go. You'll go. Good.
And
We are 2 or 20. What
Oh, that
balloon
looks
we have?
great.
I think you'll
Okay.
be able to get an excellent result
good,
with
good.
some
Very good.
perseverance. But
Fine.
I think the real decision here, the remarkable work was moving, giving up on the retrograde and giving antigrade a shot.
And just to say, so we went through what Emmanuel had published with the hybrid algorithm with the retrograde. It was the ideal case. But as he mentioned, 1 in 5, you will not be able to cross. And that exactly happened. And take this wire out. Yeah.
But I think more important, we went through all the steps of the retrograde. Emmanuel, is there something else that we did not try for the retrograde?
No, I
People
think,
want
I
to.
think you tried several septals. So the secret for that is to try several septals, which you did. Try different wires, which you did. Try different bends of the wire, which you did. Try an injection, with a 360 syringe, which we did as well. So I think you did all that you could. The septals were multiple but very small, so I think you did everything you could, and that's part of the hybrid, right? If it doesn't work one way, you want to try something different, which you did and worked out in the end.
So, Emmanuel, is there something on the horizon to give you maybe a better non-invasive evaluation about the selection of the septals between choosing of the hybrid approaches? I'm sure your group has been working on some of these issues too.
No, but that's okay. Septal.
So the main thing for choosing remains the geographic appearance. If you have nice straight connection, there's scores. There's actually Japanese scores for grading the septals and what is the likelihood of going through. Stefan Refre has shown that actually you can still cross many of the non-visible septals with the Xience wires or the polymer jacket with Xience black wires. The CT is actually not useful for septals. The resolution is not high enough to see them appropriately. So it remains an angiographic assessment and using different guide wires for getting through.
Good. Okay, get the Godzilla also. Going up.
I mean, this is what, a 115?
2020.
2020.
So the rule of thumb is that if your the over-the-wire catheter crosses the lesion, which you did here, then usually a 2520 balloon will cross. So that's how we did it.
Clearly, you went through the
2.530 or 330.
Down.
Huh? You want 3
The Xience stent was used in LED.
Yeah, no, we'll use a Xience. But question is,
Okay, go up here.
you need a bigger balloon to dilate before we stent. But go distal. There is a tight disease distally also.
Down.
We have to go distal.
Now let's take a picture, then we decide. You don't need to go 20 millimeter.
Yeah. Okay.
I'm always a believer of, when you're doing antigrade,
high pressure balloon.
you wear your proximal cap and you come out at the distal cap and you stent only the CTO. So you don't stent the entire vessel and increase the stent length. Do you agree? Unless like this one.
That's the way to go.
And unless
Because
like
the vessel will
here.
likely grow.
Put into a PDA.
Yeah. You have to go into the PDA.
Yeah. Put this in the PDA and go with the balloon a little more. Now, other question is, how much you are using string ray? I know there was some data with the initial studies that maybe dissection, antigrade dissection has a little high restenosis. And so we actually did try. We don't use it routinely. I mean, actually, even earlier, we tried just some of them. So we don't actually carry at this time. So many times when we say the CTO, people do ask, what about antigrade dissection? Re-entry. So that has not been the forte in our lab. But I'm sure every device has some use in selected cases. Yeah, good. We are 2.530.
You take another picture.
Why?
I think I want to make it very clear for the viewers. What you do is, once you open the CTO length, always take a picture. And if you think the distal vessel is a large size, does not have any disease, you just stent the CTO length. But here, when we took a picture, you see the PDA has a lesion now. So then we moved the wire to the PDA, and you got to make sure then you open that part of the PDA as well as distal RCA. So I think in the original picture, distal RCA did have a 90% lesion also. Or you see there? Yeah. So that's the key. And not stent the entire vessel. Go.
Good. We don't worry about the
very nice thing, but
can we leave this with PTCA?
No, we have to. Yeah, we'll see. We'll put a 2 stents. You need 2 stents anyway. Yeah. Before the bifurcation, you can do. Good. Let's dilate with a 2.5 and let's get a stent. 3038 times 2. Xience.
From where to where?
Distal. But put at least 1 for sure, and then we'll see.
1 where? No, this side.
Yeah, well, let's dilate proximally with the 2.530, and then we are having a 3038, 1 stent, and then we decide how many you need to put and from where. And then in the end, you can, if you want, you do the IVUS anyway. So some cases, we do IVUS, but probably in the end to optimize your stent, and that is your part of the whole complex points, which once we have time, I know it's maybe a little extra time for you, Emmanuel, till you have any time limit for you? Usually we are from 1 hour.
I'm fine. I am fine.
Okay.
It's not a problem.
Fine.
Yeah, it's not a problem.
Beautiful. Okay. Because I'll ask, I have a lot of my didactic discussion slides that will need your latest input. Although I used the latest of your white paper of circulation, and so you want to go a little distal or no? Okay. Yeah, this is the 2.530 NC emerge. Okay.
Okay,
That's
go up
good.
here, ostium.
Okay. Open the ostium. You have to come up to the ostium. Don't
Okay,
hold
good.
it much here. Yeah. Put a little wire. Good.
Okay, ready?
1 second. Yeah. I think you need to dilate a little more.
Where? No, you're okay.
Guide is out.
Come up to the ostium. Okay, ready?
Yep.
Go.
You're out. Vessel growing up.
It's,
Yeah. And AV continuation, everything is there. So far, so good. I think maybe from the acute marginal, you want to leave other thing, put a from acute margin, still will require 2 stents. Good.
Okay, 3038. Xience.
Okay. Good.
So now we start from this ectatic
Yeah,
area of
yeah.
proximal. That's
Good.
it. Distal, we leave it.
Yeah.
So
I
the
mean, this-
distal RCA, PDA, we ballooned. We are going to leave it with no further stent there. We'll just put 2 stents in the mid to proximal RCA.
Emmanuel, would that be your stenting strategy here too?
Yeah, I think it's very reasonable. I mean, there was some disease in the PDA, but
Yeah.
I think, the vessel typically grows with CTO. So it's possible that, in a few months, that vessel might be 3O plus, and you're going to put a very small stent distally. So I think it's very reasonable to put stents and cover that occlusion segment and see how it goes. The result already looks very good just with balloon angioplasty.
Yeah.
Actually, there are some people in Europe who do
Yep.
drug-coated balloons here,
Drug-coated
don't
balloon,
even
yeah.
put stents.
Yep.
They put DCBs, which we don't have, but that's an
Right.
option as well.
So that's a very good point, actually. We had a case when Colombo was a guest faculty in December, and I was surprised that some of the distal LED is a vessel size 2.5. He won't put a stent. Just do a drug-coated balloon.
Right. Samin, you were also going to be talking about that in your didactics also, no?
That's right. Yep.
Right.
Okay.
Okay, some die.
Yep. Yep.
Okay, that's it I want.
Yeah.
Okay, go up.
Go. The proximal is 3O.
23,
23.
12, 14.
Yeah. 16.
Go, 16.
16. Yep. Negative.
Go up again.
Same, we are just going to open the ostium of pulling back and put another one overlap. Yep.
This is a 38 length.
Go up.
Yeah. This was 38. Yes. 3030.
We carry 48 synergy, but we are part of the trial. 48 science.
Good. Negative.
Down.
Yes, Xience 48 trial going on. They are not approved here. Outside US, they are approved. In India, we have 48. All the Xience expeditions and so. Good.
Okay, give us
Good.
23, right?
Yeah, 23.
No need for 28.
No, 23. 23. Yeah.
And then IVUS is ready. We do the IVUS and we're good.
Yeah. And meanwhile, I can get some discussion there. As soon as you put the stent and we take the picture.
You can continue your discussion. You just stand
No,
up.
but after this, we have to show the picture first. Movie.
We would have been way long done if you had tried
No.
anti-grade.
No, but the whole purpose was to show, because of the demand, the steps of retrograde. Yes, whether it succeeded or not, we know that retrograde just added to the overall success of our CTO, whatever, 20-25% of the time. But yes, some of them may not be successful. Obvious reason which we saw today, angulation of the septal, and so yeah.
In retrospect, looks a straightforward decision, but I am, so far as the educational value, I think I'm glad we went the way it was.
Okay, some die. What do you think? Okay.
Good. Yeah. If we need 28, we can. No, still there is a room. If you want to
No.
put back.
Emmanuel, you
Yeah.
get some
28.
CTOs
I'm gonna accept
referred
that.
from across the border?
No, you have still room.
No.
Yes, there are actually a few people who come internationally for CTOs from different countries. You know, there's some of the insurance issues, but many people who are wealthy, they do come and have procedures done sometimes.
Right.
I think this is one of those areas where you know, it is important to go to a place where there's comfort in treating these complex lesions. Sometimes they can be, as you know, fairly difficult to recanalize. But this is great. I think it's what is a great demonstration here is, again, the importance of being flexible. Try one thing, another thing doesn't work, go and try to do that. And then also taking the time to optimize the result and making sure a good stenting result is achieved with those lesions.
Yeah, the run through wire. Oh, yeah, some die.
Yeah, the guide has totally lost its.
Yeah, it was because what happened, we tried to see the ostium, and
Right.
that was happened when diagnostic was being done. It was just very short proximal area. Yeah, go with the same wire. It has the memory. Good.
Same, I think if the U-loop, you get the U-loop and you think it is going smoothly, just take the U-loop in this situation. Yeah. So we are going to 325 and increase the length. Right now it changed to 2 milligray radiation. So far we were under 2.
So very well within the limits, having gone both through a retrograde and antigrade in the.
Yes. Yep. And the contrast volume is also reasonable so far. Let's see.
Emmanuel, how many interventional fellows at the institute?
We have two regular fellows and a structural fellow, and actually we just started the program. We have a CTO CIP fellow as well, so
Wonderful.
we do have quite a few.
So they probably end up doing something like 200 CTOs in their training period?
They do, and actually even the
More.
standard fellows, if they're interested, we let them participate and do some of those complex cases as well. What we've seen is that there's a lot of structural experience, but not as much people who are trained in complex coronary. So I think it's a trend that we need more good operators in complex coronary work.
Some die.
Absolutely. That has been the essence of what we've been trying to do.
And I think the same for your institution. It looks like they get a lot of experience in a variety of complexities. So that's
right.
Excellent for the
some
future.
die.
Yeah, so actually we always have been a pro fellow. Back then we always had to used to have 2 fellows back in 90s. The gradually increase, and knowing that it's a hospital, the real benefit is to the hospital. So it's not in even on the department. Looks good, right? So we actually now have
die.
Whole series of like various capacity, 13 fellows per year. 7 are our coronary fellows. 1 is the hybrid, and then we are 2 structural and 2 endovascular.
Yeah,
Okay.
So whole
now die.
Program.
Yeah.
What do you think?
Yeah, I think this is good. Right? Oh.
Okay.
Yeah.
Okay.
It's a very, we want to really cover the ostium. That's why Kini adjusting it.
Okay, good. Go up now.
Yeah. Good.
So many times what you can do is, you can have the guide inside, and as you're inflating, you pull the guide out. With this kind of, hockey stick, AL 0.75 guide for the RCA, I know they're good for difficult cases to go when you're doing distal RCA, lesions, CTO. But then when you come to the ostium and you want to place ostial stent, it's very hard to place ostial stent with this guides.
Yeah, just hold it. Let's open the ostium a little bit.
Yeah. So the teaching point for the fellows here is very clear that if you are doing proximal RCA, ostial RCA, just that one, you need to go with just a simple, FR guide. It's the best guide to place the ostial stent, and if you're going to use ostial flash balloon.
Samin, a question has come for you. The mid LAD seems to have angiographically significant stenosis. Any functional test?
No, it was just done few months ago.
No, but let's see. Let's see
let me read out his full. This is Dr. Harris. I'm doubtful the MPI shows only inferior ischemia, as angiographically the mid LAD looks significantly stenosed.
So this is that LAD now. See that now? So there are two stents in the LAD, one in the diagonal. But remember, the stent, the stress test was pre-PCI. We don't have stress test after.
Right.
Ready?
Okay, ready?
No,
So
but
this
very,
is just the pre. Yeah.
very good observation, I thought.
But it looked
But
okay.
there's no
Okay.
LAD.
Yeah. Go. The question is, can we do FFR? And I know most of the studies have shown.
Thing looks good.
You may do.
It's just excellent, I think.
You may do FFR, but as the question is post-procedure to change it to FFR, even if 30% are negative or IFR, it's to correct it very difficult. So that actually has been shown by various studies. So key is the angiographically good. If you have a focal questionable, then I definitely will go with the OCT or IVUS. But otherwise, it's the angiographically looked all right. There is some disease in the circ also.
Okay, we are going to do IVUS. So total contrast are 240 cc with the dual injection. Fluoro time is 46 minutes. Air karma is 2.097 and DAP is 166.
So this actually fits into all. So if we can see the slide, and let's hope the slides work. Can we go back to the slides, please, today? Usually these things work very well. I don't know what is happening today.
Samin, no, go ahead.
Now, to say any question?
No, we've been up to date with the questions, and I was. Let's proceed with your discussion, because what you are going to be showing is so relevant to the case which we've had.
Yeah. Huh?
I not even prepare it properly. Okay, closer. Okay, ready? Can you show the IVUS?
Yeah,
Oh,
this
no.
is this is native. Can I stop?
So let's try again while I was ready. You want to do IVUS first?
Yeah, finishing.
Okay,
Yeah,
let's do the
so then
IVUS.
I
Okay,
go
start
somewhere
recording.
else.
Yeah, it's this native vessel. So go to
While they're
proximal.
playing, let me see.
Yeah, enough lumen, enough area. Some branch. This is a distal edge. Yeah, good. Well expanded. Well opposed.
Loud.
Found from where? Where is
So
the
it's well
other
opposed.
clicker?
Well opposed. Yeah, well expanded. Yeah.
So this was the 3O stent we placed in the mid RCA.
Yeah, go to proximal. Maybe it's a lesion, CTO lesion, but it's expanded. But this is the also some branch, maybe the RV branch. Go to proximal. Yeah, looks well expanded. I think it's a overlap. Yeah, still expanded.
Yes, mid portion of the RC. Yeah.
I think so. It's a proximal part of the stent.
This is also well opposed.
Well opposed, well expanded. Wait, maybe soon the
Looks like you
proximal.
crossed the 2 to true the whole CTO, so this is great.
Yeah.
Yeah, all true. Yeah, it's a proximal. Yeah, a little bit sticking to the ostium.
Okay, that's
here.
good. We
Yeah, very
wanted
good.
that. Okay, I'm going to take a final picture with the nitro and we're good to go. We can start the lecture quickly.
We'll expand it.
Okay, let's show the last picture. So then we just go with the quickly.
Yeah. So that's a lot of nitro, verapamil, all the good things.
Anu, how much is the ACT?
Room 3 is done. Beautiful.
Looks
All
just
right.
perfect there.
Yeah.
Strong work, that's beautiful.
ACT.
Wonderful.
Okay. All right. So let's go back to the slide. While we are
ACT,
trying to find out our another clicker and so.
ACT was 330.
Very good,
Okay.
Anu.
Okay, so what we'll talk quickly, knowing that we have gone beyond our usual 1 hour, which is already 75th minute, but I hope it was very educational to our audience. And Emmanuel, just to say, it's usually about 138 countries, and monthly we accumulate about 800, 700 people online, but more important, like 10,000 plus gets it the monthly hit. So we'll talk about the recent publication CTO revascularization and the long-term survival after PCI with a drug-coated balloon, which has been the focus now because of the peripheral issues. So key is some CTO revascularization data, and I start with your white paper with in circulation with a guiding principle for CTO, and that's a very important. Those 7 points which you made, I want to put it there very quickly, but key is that what CTO we are doing is to improve symptoms. That's it. Maybe decrease ischemia, and of course various crossing strategies are there, and optimal deployment using intravascular imaging is very important for these patients. Besides the various points which we do. Now 4 important points which have been in the decision making of the proximal cap, the lesion length, course and composition, the distal vessel, and the collateral. So 4 are involved in final decision making and your development of the hybrid algorithm to which strategy should we use, whether it should be integrate dissection, retrograde, or retrograde dissection. So all these need to be carefully planned, particularly like this case. And we went through this hybrid algorithm, which you have really taught the strategy of the CTO recanalization, which you added now is the algorithm 2, where we talked about radiation dose more than 5 gray, contrast volume more than 3.7 of the GFR, procedure time 3 to 4 hours, remaining options. So if you do a subintimal plaque modification, maybe fine, otherwise bring the patient for repeat attempt. See if it is working better. Yeah, is it working? Play. So they got a new one. So retrograde CTO PCI, I just put it here, all the 10 steps. When we decide for the retrograde CTO PCI, we did everything possible, but in this particular case, it did not happen because of those collateral, and so which will happen, as you mentioned, 1 in 5 case. So the key is the CTO PCI. Why everybody talk about that? Why can't you do CTO? Should not do CTO PCI? Reason is they're still not benign. They still have some complications. Success rate, of course, Japanese they always proclaim 90-95%, but in United States most of the studies have between 80 to 90. Recent Michigan data also about like 70%. So it's kind of success rate is still reasonable. Those you decide, but look at some complication, including the death, MI, tamponade, stroke, they do happen. So clearly we cannot take the CTO lightly, because those are associated with subsequent, some in-hospital complication can occur. And of course, the in-hospital complication can occur differently based on what the strategy has been used. Some strategy have a higher complication versus some have a lower complication. So let's see now. They tell me that finally good. So now finally we got the real device, which was missing in action. So just to say that retrograde people like it, but this is the published from Progress CTO registry, which we just talked about. That overall complication, the height of the orange bar, blue bar, and the brown. So clearly that the brown, the orange bar, and so higher. Anytime you go away from the antegrade wire escalation, you start getting more complications. So clearly, if you can do integrate, it's fine. This case, we decided based on the criteria that we'll do better with the retrograde recanalization. Then there is a whole list of the CTO scores. There are 9 of them, which I enumerated here, but important one, basically the J-CTO score, Progress CTO, and the Castle score, which is being used. And I'll pause here, knowing the J-CTO is the one which we use in our cath reporting system. We produce that in every case. In this case, actually, I did not know. It was tried. So it become a J-CTO of 4. Higher the score, less is the success rate. Based on those 4 points, blunt versus tapered, calcification, bending, and occlusion length, and retry lesion. And then, of course, similar with the progress CTO, and the lastly being the Castle score, which also takes some clinical factors. So let's, Emmanuel, we need your comment here that what do you use in your daily practice in terms of scoring of the CTOs?
Yeah, actually, any of them can be used. As you say, the most commonly used ones is the J-CTO. That is the oldest and the most developed and the most validated one. But also Europe uses Castle, and we use the Progress CTO as well. But they're very similar. It has to do with the proximal cap, has to do with the complexity of the lesion length, calcification, and pressure of collaterals.
Yeah, and also it looks like that some of the other score like Castle, once you go to more severe 5, 6, they have a little better discriminatory power, because with the J-CTO score after 4, it's like gone. There is almost 0 to 10% success. So other score may give you a little bit. That's what my understanding on that. And this is basically the lot of data on the receiver operator curve and overall success. So just quickly, the radial approach, which we talked about, that how do we use radial? As you see, the largest number are either bilateral femoral or unilateral femoral and radial. So after that, one radial and one femoral is the most common. So that is what we use in most of the cases. In this particular case, we went both of the femoral and shown that while success rate does not change with the radial, actually complications, vascular and bleeding complications and following MACE decreases with the radial. Now, only I say that we need to be naive or basically very careful that all the trials of CTO recanalization, or many of them, but 3 big randomized of the Explore, Decision CTO and Euro CTO, as we all know, results are not favorable in terms of decreasing the hard endpoint. They do. Classical example is the Euro CTO trial investigator with the PCI with the DES with 2-to-1 randomization to medical therapy did show less angina frequency and better quality of life parameters and less overall angina, but as far as the hard endpoint at 1 year were not different. As you can see here, clearly the optimal medical therapy group get a slightly higher PCI, ischemia-driven revascularization, but other endpoints, death, MI is not important, not different. But if you take to 3 years, while cardiovascular death and MI were not different, but definitely the MACE was lower in the PCI group, largely driven by the revascularization. So basically, if we had to tell somebody that we are doing PCI for symptom improvement, maybe ischemia, but definitely not for the death or so. And I was very interesting to see that instant restenosis CTO versus de novo, that outcomes are better with the de novo CTO compared to instant restenosis CTO, lower MACE rate, and even success rate is slightly better in the de novo CTO and so. So with that note, I will just ask maybe Emmanuel to comment on what else in 1 or 2 sentences that we should know about the CTO in the horizon, what is going on, and any other new device which we should be looking into besides what we have spoken, incorporating the CT scan.
Well, I mean, there is many different devices. There is the, as you said, the co-registration between CT angiogram and fluoroscopy. There's a system that can actually put them both together. There are some new devices for treating calcium that are coming on board. There's, of course, the lithotripsy that's becoming available as well. But in terms of the crossing, which remains the difficult one, the main developments are in wires and microcatheters. So these are the ones that we're seeing more and more devices come out.
Good. Okay, so lastly, just my focus review of the month is the long-term survival after PCI with drug-coated balloon. As you know, this has been a big issue for the peripheries, that we are aware of the controversy about higher long-term mortality with the drug-coated balloon in PAD and survival after coronary revascularization with paclitaxial coated balloon, just in the JACC published. I'm going to ask. So the various randomized trial, the data basically showed that if you follow in the coronary, mortality within 1 year, drug-coated balloon compared against balloon angioplasty or bare metal stent or drug-eluting stent, that seems to be a favoring drug-coated balloon at 1 year. And actually in 3 years, you can see here reduction by 27%, improvement in survival. So we didn't see that signal, which was seen in the periphery, although peripheral is also now being touted again that maybe it was not right analysis, and recent data in NEJM paper shows that maybe it's not a higher mortality, but yes, this issue remain, and cardiac mortality even better with a drug-coated balloon. And this actually have put together. Question is why this happened. Within the one of the benefit occur drug-coated balloon in the instant restenosis, and possible explanation, in my opinion, are that you have lower depth dependence, less neoatherosclerosis, less additional stents in the ISR, and lower vessel and lesion thrombosis. So clearly, these are the factors, basically how the drug-coated balloon works. And so recent trial of the Picaletto in a small vessel showed the drug-coated balloon has a lower late loss compared to DES with the outcomes similar. So we sum it up. So if we say that total, what we learned in the recent publications, that hybrid algorithm strategy and radial PCI, thumbs up, double thumbs up, CTO score assessment in prediction of CTO success, thumbs up, PCI CTO in reduction of death and MI versus optimal medical therapies, thumbs down, and CTO PCI for improvement in quality of life and angina status is definitely thumbs up. And 3-year survival of the randomized clinical trial of the drug-coated balloon have shown benefit, and hopefully now we will start getting this rapid introduction of this technology in USA, which we have been waiting while it's only available for the peripheral. And so I'll ask now Anu to make any comment on from her side, knowing that she is our designated CTO operator. Of course, everybody does little CTO, but all complex CTOs are done by Anu here. And we do about 400 CTOs. We do dedicate Tuesdays and Fridays. But Tuesday usually have 4 to 5 CTOs, and Friday maybe 1 or 2. That has been our, anything you want to tell our audience, and anything based on the literature, Anu?
No, I think whatever we've shown today, retrograde, and I think for the audience, I will make sure we will pick a good retrograde case. This case actually came to see me in the office, but the same angiogram was from outside. So from the outside angiogram, I thought we could go to the septal, but I think we will put get a good retrograde CTO and show all the steps to do the retrograde CTO. Otherwise, I think antigrade we have done more of few, and next month we are going to do another antigrade CTO also, since there's a lot of request to show the step-by-step how to do the CTO. I think like mentioned by Emmanuel, it's always guide catheter as well as which dual injection is the key to make sure you have the distal vessel that's well seen, and the wire of choice, which I always say have 2 to 3 wires, polymer jacketed wire. The first one to see if you have any micro channel. Otherwise, you have your drilling wire, whether you want to go for Gaia, Miracle. It's all how you get used to these wires, and you have to be comfortable. So you don't need to have the entire armamentarium of the CTO wires. Just have few of them in the lab, and just make yourself skilled with these wires, and then to pierce the cap you may need the stronger wires. Actually, we are coming up with the next app, which is the guide wire app. Hopefully, I don't know, it'll be ready by next month. We will show all the wires that are available, workhorse wire, all the CTO wires, and various wires that will be available. That is available, will be made both website as well as the app, so people can download, so they have understanding. Because I always tell I teach the fellows and all the other junior attendings who are around, that before everybody wants to get into, I want to do complex PCI, we want to do complex PCI, but you need to know your devices. You need to know your wires. So okay, if this does not work, what is my next wire choice? So you have to understand. So that is why this particular website and app will help you to have, it's not an extensive book, but very brief. It'll give you idea about all the wires that is available, so then you make yourself comfortable to have these wires, and familiarize yourself, and then start using them, and then try to become the master.
Great. So let's quickly, Emmanuel, we end this, and then we'll take a last note from you. The following statements are true regarding the CTO hybrid algorithm strategy and outcomes. Antigrade wire escalation is most frequent with lowest complications. Antigrade dissection re-entry may have higher restenosis. Retrograde wire escalation strategy is preferred in ambiguous proximal cap. Retrograde dissection re-entry has the lowest in-hospital complications, and IVUS can be helpful in antegrade wire entry. Clearly, retrograde dissection has the highest in-hospital complications as per your Progress CTO registry. RCT, randomized clinical trial of CTO recanalization comparing PCI versus optimal medical therapy showed the following, except similar MACE rates at 1 to 5 years of follow-up in two groups, lower death rates at 3 years after PCI versus optimal medical therapy, better quality of life and SAQ scores after PCI, lower revascularization after PCI versus medical therapy, and lower angina frequency after PCI versus medical therapy. Clearly, B is the wrong answer. There is no lower death rate. The final question, following statements are true for the long-term outcomes of randomized clinical trials of drug-coated balloon versus comparator device in coronary arteries, except trend towards lower mortality after drug-coated balloon, significantly lower cardiac mortality after drug-coated balloon, higher device thrombosis in drug-coated balloon group, trend towards lower late loss versus DES in small vessels, and overall MACE rates after drug-coated balloon are comparable to the control group. Clearly, we know that there is no high device thrombosis in drug-coated groups, so it's a wrong answer. With that note, we end our session aside with the last final note from our esteemed guest faculty, Emmanuel. It was very wonderful. We thank you to be a part of this fantastic educational session, and we need kind of closing statements from you.
Well, again, congratulations. It was a phenomenal case, excellent demonstration, and excellent didactics. Thank you for having me, and congrats again for a phenomenal case.
Emmanuel, thank you so much for sharing your intellect and your expertise. We often have guest faculty. I can tell you today we matched it exactly right to the case, and you were absolutely wonderful. Thank you for joining us. Anu and Samin, great educational case, superb skills, Anu, and we'll conclude here and see you during the next session on March the 16th.
Thank you.